The disease with 1,000 faces. Difficult to diagnose, complex, and chronic. It will strike 1 in 900 Canadians. Lupus. This autoimmune disease alters patients' lives, and if left untreated, can be fatal. At the BC Lupus Society, we provide support to people living with lupus. Because lupus is unpredictable, we strive to be dependable. Our programs include weekly support groups for patients and families in British Columbia. We make sure that educational resources and peer contacts are always available, including for patients facing a new lupus diagnosis. And every year, we help fund clinical training and medical research that benefit people with lupus. Through the BC Lupus Research Scholar Program, our goal is to advance treatments and discoveries to change the future of lupus. Our partnership with university researchers is unique in Canada and has helped understand the full impact of lupus and the effectiveness of lupus care. As part of our community, you're a valued part of annual events like our Lupus Gala and the Shed Light on Lupus Walk. These fundraising activities generate just part of the funds needed to sustain our work in patient support and medical research. With the generous support of donors like you, the BC Lupus Society will continue to be here for patients and families affected by lupus. Not only can we change tomorrow, we can brighten today. Thank you from the BC Lupus Society.
Hi everyone, my name is Neda Amiri. I am the Director of the Pregnancy and Rheumatic Diseases Clinic here at University of British Columbia, and today I will be talking to you about family planning and pregnancy in lupus. So the first thing I want to talk to you about is planning a pregnancy in lupus. And I have to preface this by saying the best pregnancy in lupus is a planned one. A lot of patients sometimes think that because they have lupus or because they have high disease activity, they can't get pregnant. That is not true. Lupus, regardless of disease activity, does not appear to affect fertility, although some medications that we use, such as cyclophosphamide, can affect a woman's ovarian reserve. Overall risk of having lupus in a baby who's born to a mother or a father who has lupus is very low, although genetics play a role in presentation of lupus. We know that it's not the whole story and that there are a lot of environmental factors that play into development of lupus. So having said that, having reliable contraception prior to planning a pregnancy is key. So let's talk about what the best form of contraception is. Intrauterine devices remain the contraceptives of choice for women. So in terms of the different kinds of intrauterine devices, Mirena or Kyleena, which are progesterone-based IUDs, are best, although copper IUD can be used. The difference is with copper IUD, there tends to be a lot of breakthrough bleeding, whereas Mirena and Kyleena tend to minimize the amount of bleeding. And I should also say that these IUDs, the effect that they exert is from a hormonal perspective, it's all very local, and the amount of hormone that they have in them does not affect the whole body. For patients who have low disease activity, they can use oral contraceptive pills. So these are often pills including both estrogen and progesterone. But if a patient has moderate to high disease activity or they have antiphospholipid antibodies, these pills should be avoided. We all know accidents can happen, so if there is a breach in contraception or if there's an accident of any sort, all patients can use the Plan B, which can be purchased from pharmacy without a prescription. So this includes patients who have antiphospholipid antibodies or patients who have moderate to high disease activity. Patients obviously ask about barrier contraception, so the most common one being in the form of using condoms, and these can be used, but unfortunately they can have 10 to 20% failure rate. Let's talk about pregnancy outcomes in lupus. So patients who enter pregnancy in a low disease state, they're most likely to have a healthy and uneventful pregnancy. And that's how we like our pregnancies, boring. So the best studies that we have show that over 80% of patients with lupus who go into pregnancy in a low disease state can have normal pregnancies. So with that in mind, we advocate for at least 6 to 12 months of low disease activity, or what we call quiescence, prior to planning a pregnancy. So why do we fuss about this? It's because patients who have lupus have been shown to be at increased risk of miscarriages, having preterm birth. So that's birth that's before 37 weeks of gestation. Most pregnancies go until 39, 40 weeks of pregnancy. Small for gestational age infants, so babies who are on the smaller side. So babies who are usually less than 2.5–2 kilos, and preeclampsia. Preeclampsia can have different manifestations, but some of the most common manifestations are high blood pressure, protein in the urine, having abdominal pain, headaches, and in the most severe form, unfortunately, seizures. So what about lupus disease activity in pregnancy? So it's true, lupus can flare in pregnancy, but as I mentioned, if we go into pregnancy in a low disease state, our chances of having a flare are lower. So having a mild to moderate flare is somewhere between 10 to 30%, and this tends to be flare in the joints and skin, which are easier to treat. Severe flare is much lower at a rate of around 6%. After delivery, because of again all the hormonal changes, there can be an increased risk of flare. This is around 30% for mild to moderate disease, and around 2% for severe flare. You may hear your rheumatologist talking about neonatal lupus. It's important to remember that this is not the same as having full-blown grown-up lupus. Neonatal lupus develops because the mom can pass on certain antibodies to the baby. So the most common antibody that causes neonatal lupus is SSA antibody. So the manifestations of neonatal lupus can be rash, congenital heart block, low blood count, so in form of having low hemoglobin or low white blood cell count, and having elevated liver enzymes. So let's talk about medications, because most, if not all, patients with lupus tend to be on medications. I hope all patients with lupus are on hydroxychloroquine. We particularly value hydroxychloroquine in pregnancy because it has been shown to reduce risk of disease flare in pregnancy, reduce rate of miscarriages, and even possibly reduce risk of preeclampsia. There's also some data that shows that for patients who have SSA positivity, it can reduce the risk of congenital heart block in the babies. And with all that said, it is of course safe for both mom and baby, so it's safe for pregnancy and breastfeeding. There are lots of other medications that we use in lupus. I should definitely mention medications that cannot be used in pregnancy. So methotrexate, leflunomide, mycophenolate, and cyclophosphamide. Each of these deserve a talk on their own, but because either they increase risk of miscarriages or birth defects, or in the case of cyclophosphamide, they increase risk of ovarian insufficiency in women. That's why we cannot use them in pregnancy. But thankfully, we have lots of medications that can be used in pregnancy. Prednisone definitely can be used in pregnancy, but we know that prednisone, especially at high doses, can have lots of side effects for the person who's taking them. This can be weight gain, high blood sugars. So we like to minimize the dose of prednisone prior to pregnancy. So make sure the patient goes into pregnancy with prednisone doses ideally below 10 milligrams. Azathioprine is safe in both pregnancy and breastfeeding, as is tacrolimus and IVIG. Rituximab can be used in pregnancy, but we try to time it so we use it earlier on in the pregnancy. As some of you know, there are lots of biologics that are emerging in the field of lupus. So I don't have the time to talk about each of those individually, but some of them can be used in pregnancy, and we have used them with good results. But those would be cases where we would have to discuss it on an individual basis. Aspirin in pregnancy is worth a mention. So aspirin in general has been shown to reduce risk of preeclampsia. So this is in kind of all comers. But most patients with lupus are also recommended to take aspirin in pregnancy because, as I mentioned, patients with lupus can be at increased risk of preeclampsia. So typically aspirin is started somewhere around 12 weeks of pregnancy, and we continue it all the way through to 36 weeks of the 36th week of pregnancy. There might be some additional risk factors that predispose a patient to preeclampsia. This can include history of having preeclampsia in a prior pregnancy, having diabetes, and this doesn't matter if it's type 1 or type 2, having hypertension, if it's a twin or even a triplet pregnancy, and having kidney disease. Other things in pregnancy that should be considered are exercise, adequate calcium intake, vaccinations, and cervical cancer screening. So exercise in the form of 150 minutes per week has been also shown to reduce risk of preeclampsia. Calcium, 1,000 milligram or equivalent has also been shown to reduce risk of preeclampsia. We prefer if patients can consume their calcium from diet source, but if patients don't tend to eat dairy products or have a more limited diet, they can certainly take calcium supplements. There are a number of vaccinations that are recommended in pregnancy, so definitely influenza vaccine if you're pregnant during the flu season. COVID vaccination has been shown to be safe in pregnancy, and all pregnant women, regardless of whether or not they have lupus or not, are recommended to have Tdap vaccination. So Tdap vaccination includes pertussis, And pertussis is this same bug that causes whooping cough in babies. And that has so when mom gets the vaccine in pregnancy, this has been shown to reduce the rates of whooping cough in the babies. Studies show that patients with lupus are at increased risk of cervical cancer, so we recommend that all women with lupus should have annual cervical cancer screening. So let's come back to our take-home messages. Healthy pregnancies in lupus are possible. Planning ahead and achieving low disease state prior to pregnancy is very important and has been shown to improve pregnancy outcomes and reduce risk of flares. If there is SSA positivity in mom, or if mom has a positive SSA antibody, they will need closer monitoring of the baby's heart rate between weeks of 16 and 26 weeks. Hydroxychloroquine use is very important in pregnancy and has been associated with lower rates of disease flare and lower rates of miscarriage. Many other medications are available in pregnancy that can be used safely. Thank you for your time. I'd be happy to address any questions, and you can have them forwarded to me through the administrators of the meeting. Thank you so much for hosting this important conference. Take care. Bye.